What is this formula? Yeah. No idea?
No idea, sir.
No one? Okay, this is called the Nernst equation. That name sound something? Where is it used?
Sodium.
Sodium.
The nerve.
What is Nernst equation? Where is it used? Okay. Name the various components of this equation. Here you have the letters E, R, T, Z, F, X, O, X, N. Okay, right. So this is the E is the membrane potential in voltage. R is for the gas constant, and S is for the Faraday current constant. X is concentration of ion outside the cell, concentration of ion inside the cell. Z is the number of electrons, and T is the temperature in Kelvin. So this is the equation or formula to calculate the resting membrane potential of all the cells in the body. This is a very, very important basic biological knowledge that we should possess. Okay? So what is resting membrane potential? The answer is here. When ions are present outside and inside the cell, the ions, do they have electrical charge? What is an ion? Definition. A chemical possessing an electrical charge is an ion. Okay. So sodium, potassium all have positive charges. Chloride, bicarb have negative charges. So they call it as ions. Isn't it? Basic chemistry. So resting membrane potential is the equilibrium between the inside and outside. Resting membrane is the electrical potential difference across the cell membrane of an excitable cell when it is in a non-excited state. This is the definition of resting membrane potential. Electrical potential difference across. What is the normal electrical status of the inside of the cell? Electronegative. Why so much of hesitation? Only when you understand this, we are going to understand the action potentials and other things, isn't it? So cells are always electronegative. When this negativity becomes too low, what is that called? Normal electrical potential inside a majority of the cells is between 70 to 90 negative millivolts. Okay? Supposing it becomes minus 110, which is much more higher than minus 70 or 90. What is that state called? It's called hyperpolarization. Okay? The drugs, some of the drugs we are all causing by infusing or allowing chloride to enter the cell, which has a negative charge. Okay, this inside negativity becomes much more, which is called hyperpolarization. That is the mechanism of action of your which drug? Induction agents, which we use. Whole class is silent. Right? So GABA and the testosterone, all those things cause negative hyperpolarization. Okay? So this is the resting membrane potential, is the electrical potential difference across the cell membrane of the cycle cell. What factors determine the resting membrane potential?
Membrane permeability.
Fantastic. Membrane permeability. They are all semi-permeable. Some ions pass through easily, some ions are not allowed to pass through easily. So that is why they are called semi-permeable membrane. Which ions can cross easily, which ions are prevented from crossing easily? Between sodium and potassium, which one can traverse across easily, which one cannot traverse so easily?
Potassium travels.
Potassium can always travel easily, okay, whereas sodium requires a pump. Okay, so
Yes.
permeability of the membrane to different ions, relative ionic concentration on either side of the membrane. So these are the two things which determine the resting membrane potential. And what is the importance of this Nernst equation in anesthesia? Why should we know about this? The reason is it is used in anesthesia to understand and predict ion potentials across cell membrane, which is fundamental to nerve signaling, especially. Okay? And Nernst equation does not directly cause anesthesia, but helps to explain the mechanisms by which anesthetics can influence nerve cell function, which is central to the process of anesthesia. Okay? So how sodium enters, how potassium extrudes, how the resting membrane potential becomes threshold potential, then excitation potential, then how it is restored back. So how does the depolarization happen? How does the repolarization happen? All these things are based on this. Okay, so that
Yes.
is the reason why which is not taught well for majority of the students, but it is one of the important things, especially if you go to UK or other countries. These are all the basic things which they will find out your knowledge. Like see that you have basic concepts. Well. That is the reason why this question has been asked. Now there is a clinical scenario. A 26 years old lady stiff fall from two-wheeler and sustained injury to the right leg brought to A&E crying in pain. Her ABG shows the following values. pH is 7.56, PCO2 is 31 millimeters of mercury, CO2 120, bicarbonate 25 milligrams. What is your interpretation of the ABG? Hmm? What is the diagnosis?
Respiratory alkalosis.
Respiratory.
Respiratory alkalosis, acute or chronic?
Acute.
Acute.
Acute. Okay. Acute respiratory alkalosis. What are the features to say it is acute respiratory alkalosis?
No bicarbonate compensation.
That's the main thing. What should be the bicarbonate compensation? Will it become low? See, first here is CO2 is low and pH is high. Bicarbonate is normal. That's the third thing that we have to say. Okay? PCO2 is lower, pH is higher, and bicarb is normal. So what will happen if it is a chronic respiratory alkalosis? What are the changes you expect in chronic respiratory alkalosis?
pH will come to normal level.
pH will be
Compensation.
normalized. And PCO2 will be still low to say it is respiratory alkalosis. And bicarb will
Bicarb will be
secreted
reduced.
by the kidney. Okay? That is the time when bicarbonate will come down. So that is how the compensation takes place. So if the pH is still on the alkalotic side, it is an acute condition. On the contrary, if the pH is 7.4, which is a normal value, and bicarb is 15, then it is a compensated state for chronic respiratory alkalosis, where PCO2 is getting knocked down. What is the cause of this change in this patient?
Pain,
Pain
Hyperventilation.
and anxiety causing hyperventilation.
Hyperventilation.
Now, how to correct this? Sudden spells of silence. Silence. This is caused by pain and anxiety. So what you have to
adequate
do?
analgesics.
Analgesic, immobilization of the injured limb, and counseling and pacify the patient. Okay? Once they start stop the hyperventilation, automatically things will fall in. Okay? What is the what is intentional hyperventilation and why was it done? It's not accepted now, but that's why I put why was it done. This is the discussion I had during our earlier discussion of pneumothorax. The olden days, we used to do this intentional hyperventilation as anesthetist. Anesthetists used to intentionally hyperventilate during controlled ventilation as a measure to reduce ICP during neurosurgery in the olden days. To avoid use of muscle relaxant towards the end of the surgery and in pregnant patients, okay, till the baby is delivered. So why this practice is given up is earlier they thought by reducing the blood carbon dioxide level, it will cause vasoconstriction. So that will reduce the ICP. So as a temporary measure, when the surgeon is doing a intracranial procedure, when they open the stowel and the dura is bulging, we used to hyperventilate and reduce the blood flow to the brain and reduce the tension ICP, and the dura will automatically go back to its normal place. But later on, they found that the blood supply to the neuronal tissues is already compromised by raised ICP. So by further reducing it by hyperventilation causes more ischemia. So nowadays, normocapnic ventilation is the rule for any neurosurgical procedure. You have to resort to other techniques like giving mannitol or reducing moving the CSF to reduce the ICP. They are the accepted methods for reducing the ICP rather than intentional hyperventilation. Similarly, by hyperventilating, we washer the carbon dioxide, the calcium level in the blood will drop. That will reduce the conduction at the muscle level and muscle relaxation will continue. So you can avoid giving extra dose of relaxant and allowing the paralysis to continue so that the recovery will be delayed. So that also used to be practiced, which is again not necessary nowadays with the very short acting muscle. And in pregnancy, all of you know that pregnant mothers have a slight respiratory alkalosis throughout pregnancy, which we have told why the reason is to eliminate the carbon dioxide from the fetus. So during GA for pregnancy and the operative delivery, we do that same hyperventilation to keep the CO2 level low till the baby is delivered. Once the baby is delivered, then we can return to homeopathic ventilation. So these are all the implications for that intentional hyperventilation. What is done here?
Ultrasound guide of ankle blocks, sir.
Which nerve you are blocking? Is the entire ankle nerves are blocked?
Posterior tibial nerve.
Posterior tibial nerve block. Where US guided ankle block, of which you are blocking the posterior tibial. What are the nerves to be blocked for the block?
Superficial peroneal nerve, superficial peroneal, deep peroneal, sural nerve, saphenous nerve, and tibial nerve.
These are all the areas supported by that. Can you perform ankle block for this case?
No, sir.
Why?
The local anesthetic won't take due to the pH changes.
Not advised as the wound looks infected. Okay, so in infected area, we give anti-block. What will be the pH in this area?
Low, sir. Acidic.
Acidotic. Okay, in
Acidotic.
acidotic, the drug won't get is nerve stimulator useful in doing ankle block?
Yes, sir.
How many of you agree that it is required or useful?
No stimulator.
No, because most of them are sensory in use. Okay, all of them are sensory. They don't have a star component. So it is not useful. Now there are a few pictures of capnography. Can you identify?
Hypoventilation and hyperventilation, sir.
Hypotension. Gradually increasing. Waveforms seen in shock and the leaking alveoli. Okay. What is this pattern?
Torque in appearance, sir.
Bronchospasm.
Bronchospasm. Okay, very good. What is this?
Expirative valve obstruction.
Respiratory valve.
Respiratory valve obstruction. This hump is very classical. In the patients. See, this is the plateau which is going there. It should suddenly drop like this. Isn't it?
Yes, sir.
Whereas it is going up and then coming down. So waveform seen in poor compliance like especially obesity and pregnancy. So that is where the peak goes up. What is this? Initially, VPCO2 is low. Suddenly it picks up and becomes big.
Malignant hypertension.
Malignant hyperthermia, it will be going on increasing. CO2 will be gradually increasing. But here it is quite low and suddenly becomes almost normal. Return of spontaneous circulation.
ROS.
Okay.
Yes.
You have capnography seen in advanced airway placement or intubation. There are 4 different presentations. What is this first presentation? Second, third, and fourth. Here, there is no waveform. Suddenly, it comes. So, what does it indicate? Of course, thing like this. So, it is like the same condition like this. 4D. Okay. So, apnea followed by normal beginning. That is the first one. Patient is apneic, suddenly starts breathing normally. The second is airway secured but not properly. Some intubation has been done, the waveform is not looking normal. The 3 is a normal pattern. So it goes up, the plateau is there, then it's coming down. So this is a normally placed airway. And the 4 is initially it has become normal, then again disconnected or arrest again. So this is again becomes flat. What are these two things?
It's a hypoventilation.
This is where hypo and
Hyperventilation.
hyperventilation. You know, gradually the ETCO2 peak level keeps on going down. So patient is hyperventilated, the ETCO2 level is falling. Whereas here it is gradually increasing. So patient is accumulating CO2. So this is hyperventilation. This is hypoventilation. Hyper and hypoventilation. Can you identify this person?
Sashakri Mallampatti, sir.
Ah,
Sa-
name is
Sashakri
Rao Malambati. Right. What is his contribution?
Mallampatti classification, sir. Original
Malambati
Mallampatti.
classification. Very good. To assess the degree of difficult intubation. How many classes were there in his original
Three.
description?
3, sir.
Three classes. And who modified this classification and how?
Samson and Young.
Samson and Young.
Samson and Young modified that and added a class 4 on. What is upper lip bite test and who proposed it?
Upper lip bite test has 3 class, sir. Class 1 is touch above the vermilion line,
Now,
and
what is upper lip? I'm not asking what are all the grades of upper lip bite test. What is upper lip bite test?
to see the prognathis.
It is an alternate to Malambati test to find out. So it is the ability to bite the upper lip with a lower teeth to assess the degree of difficult intubation as an alternate to Malambati score. It was proposed by Khan et al. In 2003. What is this?
Mnemonic of MPG grading, sir.
This is a mnemonic to remember what are all the structures you see in the various grades of Malambati. E stands for pharyngeal wall, U uvula, H soft palate, H hard palate. Then grade 2, you don't see the pharyngeal wall, you see only the uvula, soft palate and hard palate. Grade 3, you see the soft and hard palate. Grade 4, you see only the hard palate. This is a mnemonic to remember the structures seen. What is shown here and how is it useful?
One.
What is being shown here? This is called laryngeal handshake described by Dr. Richard Levitan. Okay. So here first they hold the hyoid bone, the thumb and the index finger. Then they slowly slide down over the brachial cartilage, then the cricoid cartilage, and then finally when they hold the cricoid cartilage, they put the index finger to find out the gap between the thyroid and cricoid to identify the cricothyroid membrane. Okay. So sliding the hand like this is called the laryngeal handshake. And this helps to identify the cricoid cartilage and cricothyroid membrane in situations of can't ventilate, can't intubate to achieve the front of neck access. What is shown here and where are they used?
Fentanyl,
They are
OPC poison.
compound. They are used as pesticides. What are the symptoms of organophosphate compound poison?
it is
Muscarinic
Blood.
symptoms, nicotinic symptoms, and central symptoms.
Which system they do affect mainly?
Nervous systems.
Which nervous system is motor, sensory, autonomic. Autonomic is sympathetic, parasympathetic. It's the parasympathetic system. So it affects the nicotinic receptor stimulation, causing the neuromuscular junction, autonomic ganglia, adrenal medulla, muscarinic receptors are also stimulated. Something in the heart, pupil, etc. Various manifestations like weakness, fasciculation, cramps, tachycardia, hypertension, anxiety. Then once the heart gets completely blocked, it will cause bradycardia and hypotension, blood ocean. So it is mainly the nicotinic stimulation of the parasympathetic system. The mechanism, how it does is, which enzyme it will affect?
acetylcholinesterase.
Acetylcholinesterase. So they activate the acetylcholinesterase phosphorylate the active sites of acetylcholine space and inactivate the enzyme. So what will happen? The acetylcholine that is produced will keep accumulating in the body, producing what is called the cholinergic crisis. That is what is happening in OPC crisis. And normally, how is the acetylcholine metabolized by this enzyme, acetylcholinesterase? So basic question sometimes may be asked in the exam. If they ask you or discuss about neuromuscular transmission. So the acetylcholine trace has got two sites of activation. One is called the anionic site, another is called the esteratic site. So the acetylcholine, which is a compound like this, will be attached to these two sites. And that will be broken down into acetic acid and choline. This is the normal way. So when the OPC poisoning occurs, it will come and occupy this esteratic site. So the acetylcholine cannot come and attach to both the sites. Only when it gets attached to both the sites, it will be broken down or cleaved into these two components. So once this site is blocked, then the acetylcholine cannot be broken down. It will be going on accumulating more and more. And once the level of acetylcholine goes up, it will produce all the parasympathetic stimulation of proteinuria and muscarinic. So how to treat OPC poisoning?
Atropinization, sir. Do you
Hospitalization for bradycardia if it is there. But take first from
Pralidoxim,
the
sir. So pralidoxim, inactivate the enzyme pralidoxim, sir.
pralidoxim. From the beginning, what you have to say is decontamination, supportive therapy, blockade of muscarinic activity there, in reversal of cholesterol with toxin, correction of metabolic abnormality, prevention of infection, and if there is muscle weakness and inadequate respiration, they may require intubation and ventilation. A 62-year-old male with history of diabetes, 15 years, admitted with vomiting, fever, rigor. Patient is drowsy, tachypneic, tachycardic, febrile, dehydrated. ABG taken, room air, temperature 38 degrees centigrade, shows the following values. Which is 7.28, PCO2 24, ICAM 14, CO2 82, HHS minus 11, sodium 138, chloride 92, calcium 5.9, glucose 390, ketones 3.4 million. What is your interpretation?
Diabetic.
Huh?
High anion gap metabolic acid. Diabetic ketoacidosis, sir.
Ketoacidosis. Is there a compensation? This is always start from the pH, go to PCO2, then PCO2, then write up.
Yes, sir.
So
Because
this
it's
is the acid pH or alkaline or
acidic.
acidic pH.
Yes, sir.
PO2, is it normal or low?
Low, sir.
PCO2 is
It's
low.
low.
PO2 is bicarb 14, is it low or not?
Low, sir.
Low. PO2 is also low. So partially compensated metabolic acidosis with respiratory alkalosis, high anion gut, hyperglycemia, ketonemia, hypoxia, consistent with diabetic ketoacidosis. This is the full interpretation. What indicates partial compensation of metabolic acidosis?
The respiratory PCO2 should be
PCO2
decreased and the
PCO2
pH also.
So the reduction in PCO2, pH is not come back to normal. So that is called, that way it's called partial compensation. How is anion gap calculated?
Unmeasured anions in the so unmeasured anions minus unmeasured cations, sir.
Sodium plus potassium minus chloride bicarb. The anion gap here is 37.9. Is it normal or high?
Increased, sir.
Very high. What is delta gap in this case and its significance?
Change in anion gap by change in bicarbonate, sir.
Bicarb, change in the anion corresponding ratio. So delta gap is equal to delta anion gap divided by delta bicarbonate. So here it is 37.9, and here from 24 it has become 14, so it is 10. So it is 3.579. So it is high anion gap alkalosis with pre-existing alkalosis. That is the importance of delta gap. How to treat decay?
First, IV fluids
Hmm.
in normal saline, 50 to 20 ml per kg. Then insulin infusion for 0.1 units per kg. Then potassium correction. Then bicarbonate, sir. If pH
Oxygen
less than
supplementation.
7.
So first ABC survey, oxygen supplementation, hydration with saline, plain insulin 0.1 per kg bolus followed by infusion. Check potassium from second hour and treat if it is below 3.5. That is all the steps you have to do. Identify the structure seen here. Immunoglobulin, very good. This is what are all the immunoglobulin? Name
FC
the
portion, FC portion of immunoglobulin, alpha chain, beta, light chains, and
light chain and
heavy.
heavy chain. Name the various parts. That there is one part, various parts. What is this? Are you able to see my
Hinge.
cursor?
Yes, sir.
This is the
Hinge.
disulfide bond. Okay. So the various parts are antigen binding sites. These are the antigen binding sites. We have the light chain and a heavy chain. Then we have a disulfide bond. Then we have the constant region, that is the variable region. The thick blue is constant region. The light blue is called the variable region. Under what category of immune system these immunoglobulins are produced?
B cells, sir.
Huh?
B cells, sir.
Cells. Immune system, how are they classified?
Helper
Humoral
cells and
immunity and cellular immunity.
immunity.
Which category it will come?
Humoral immunity.
Humoral immunity.
Immunity.
What is the other type of immunity? Cellular immunity.
Cellular immunity.
What is the most common immunoglobulin?
G and M, sir.
IgG, that is the maximum. What are the effects of anesthesia on immune system? Do they suppress the immune system or do they keep the immune system?
It will suppress the
alive
immune
or-
system, sir.
Anesthesia
In opioids and
suppresses some immune functions. It may cause increased infection risk and tumor metastasis. The anti-inflammatory effects can be beneficial in conditions like systemic inflammatory response syndrome. What is seen here?
isomerization.
Very good. It is not a medicine. Central solution, soluble, soluble, acidic state. What is the other name for this condition? Not a medicine. Called dynamic isomerism. What is a racemic mixture? Earlier, most of the anesthetic drugs we had were all racemic mixtures. Now we are trying to separate them and try to pick out a particular component. Because we found that the effect will be better and the complications are less.
Adrenal
Based on this, waste mixture has equal portions of dextro and levo forms of different enantiomers. Okay, the enantiomer is in a dextro form or levo form. So when there are equal proportions of both dextro and levo form, it's called a racemic mixture. Now we are trying to remove that is why ketamine, which was originally contained both dextro and levo, we are trying to bring out R-ketamine. Similarly, bupivacaine, which had a equal proportion of dextro and levo, now we are using levo bupivacaine because it is less cardiac active. Okay, so remember that the racemic mixture is a drug which has equal proportions of both dextro and levo or different. What is an azeotropic mixture? This is historical. No mixture of halothane and ether. Two liquids with a constant boiling point is azeotropic mixture. An example is ether. What is a eutectic mixture?
It is a equal proportion of local anesthetics in the same.
Same.
If two local anesthetics different melting points in equal measure, it is two new melting
They
points.
attain a new melting point.
New
Okay.
melting.
That is called eutectic means boiling or temperature. So eutectic means same temperature. So two different boiling point substances, when they are mixed in equal quantity, they attain a new temperature at which they will boil. So they will remain as a cream without becoming liquid. That is the reason for vanilla cream being used. It's seen in this. You can see the color of the cylinder.
Nitrous oxides, blue color cylinder, nitrous oxides.
With nitrous oxide alone,
Entanox.
Phenox.
with a dispenser. Okay, these are all the. What is unique about this valve? The demand valve which will open when inspiration occurs to create a negative pressure. So that patient will inhale only if they take a setup. Otherwise it will not deliver. Like your anesthesia machine is a constant delivery machine. If you open the flow meter, it will continue. So here, what is pointing effect? Called the dissolution of gaseous oxygen in bubble through liquid nitrous oxide. Vaporization of the liquid comes to form a gaseous oxygen. So of nitrous oxide is usually at room temperature in the liquid form. If you force oxygen gas to blow through this pressure, both nitrous oxide and oxygen will become a gas to a mixture called Entanox. Why it is called Entanox?
50% oxygen and 50% nitrous oxide.
It is symbol N2O. N2O plus MOX. That is how the name was got. N2O is the symbol of nitrous oxide. OX is the symbol of oxygen. O2. That's how it is. What is pseudo-critical temperature? Critical temperature of nitrous oxide is 36.5 degrees. But in the mixture with oxygen, this is lowered to minus 5.5 degrees centigrade. This is called the pseudo-critical temperature. So when two different gases are mixed together, we attain a new temperature. This is called the pseudo-critical temperature, beyond which it cannot be compressed. What is lamination? Ethanol is supplied in cylinders at a pressure of 137 bar and be stored above pseudo-critical temperature of 36 degrees. Below the temperature, what will happen? Nitrous oxide liquefies into, again, from gaseous state, it will become a liquid. This is called lamination. What is a eutectic mixture? We assume when two drugs with two different melting points, not boiling points. The melting point mixed in equal proportion, they attain a new melting point and remain semi-solid state. What is it? Why does it require an occlusive dressing for applying blood? Are you all using this? Do you use this again? Using this so that it will remain in contact with the skin. What complication can occur if applied to a raw area?
Methemoglobinemia.
Methemoglobinemia. How to treat methemoglobinemia?
Methylene 1 to 2 gram. Wow, methylene blue.
Give
Sir.
IV methylene blue, give 5 minutes or injection ascorbic acid 900 gram IV. What is this person doing? This is the patient and this is estimating. Of course, his fingers are all blocked. He is seem to be listening to something. The
Look at the
index
R and
shows-
C for blind intubation, sir.
He's trying blind nasal intubation. Okay? He's listening to the breath sound. What is shown here?
Retrograde intubation.
Retrograde intubation. Very good. So, guide wire is passed through the brachiothoracic membrane, pulled out through the oral route, and it is being threaded here. So, this is the retrograde intubation. What are all the structures you see here? This I showed in the last class.
Atomizer.
This is mucosal atomizer device. This must be commonly seen.
Nasopharyngeal.
Nasal airway or nasal trumpet. Okay. The items above, this is called Parker-Usiker articulating tracheal tube. And this is the Wolf-Torrey mucosal atomizer device. Then this is the endotracheal tube, nasal trumpet or nasal airway. This red thing with which he is listening to the sound is called Beck Airflow Airway Monitor or BAM visual. It's called Beck Airflow Airway Monitor or BAM visual. Interpret this ECG.
S1Q3T3.
The rate.
Always if you go in a methodical way, is there a proper P wave?
No,
Do
sir.
you have a QRS following? Do you have a T wave? That is how you start. First you see from lead 1, lead 2. Is there a proper P wave?
No, sir.
No. So,
Action.
what is it? Atrial fibrillation.
Yes.
What is the ventricular rate in this? Atrial fibrillation, atrial rate is
150.
higher than ventricular rate. How to calculate the ventricular rate using this?
150 to 180, sir.
Is it a rough way of telling or exactly
300 divided by number of
300?
300 divided by number of small boxes between R and N.
That is for regular
Yes.
If you have a regular ECG pattern, RR interval is normal, that is the calculation.
Yes.
But here, you can see the irregularity here. You can see the gap is more here, gap is less here. So when the pulse is irregularly irregular, how to calculate the particular rate? You can see the irregularity here. The V3 seat with the gap here. Okay. So pulse is irregularly irregular. That case, how to do that? Count the number of R waves in the long strip. Okay. Some ECGs, they take the long strip or rhythm strip for 10 seconds based on the number of steps you can calculate. Or some ECGs will have the rhythm strip only for 6 seconds. Okay. So if it is for 10 seconds, count the number of R waves and multiply it by 6. Then you will get the particular rate. Or if it is a 6 seconds rhythm strip, multiply it by 10. So here if you see, this is 1 R wave, 2, 3,
22, sir.
5. So there are 22 R waves here. So 22 into 6 is 32. So you can exactly say how many ventricular rate. What are the causes of atrial fibrillation? This is a very, very common
Mitral
ECG
stenosis,
that we have to know.
cardiac causes, non-cardiac causes, mitral stenosis, sir. Thyrotoxic.
So you can remember it by these mnemonic pyrates. Pulmonary causes, embolism, IHH equals to ischemic or infarction, rheumatic heart disease, alcohol anemia, ketoacidosis, toxin. How do you treat this condition?
Rate control, rhythm control, and anticoagulation, sir. Before that, hemodynamically stable and unstable.
First thing, assess hemodynamic stability, stable, unstable. Stable cardioversion with 100 joule. Stable, then rate rhythm control with esmolol, amiodarone, digoxin, anticoagulation, heparin. Describe your findings.
Low bronchitis.
Right. Left-sided pneumothorax.
Left-sided pneumothorax. What type of pneumothorax? Normal pneumothorax or tension?
Tension pneumothorax.
How do you say it is tension?
Left lung is collapsed and the heart is pushed to the right.
You can see the tracheal shadow itself is curved. HSPAO, no bronchovascular marking seen on the left side. Deviation of tracheal shadow to the right. Dark air shadow in the left pneumothorax. Collapsed lung. Ends up tension pneumothorax. What causes this condition?
Trauma.
Is there any classification? Can be spontaneous or acquired. But spontaneous, it can be primary due to subpleural blood rupture or pleural rupture, secondary to COPD, tuberculosis, malignancy, etc. Acquired can be trauma, blood trauma, penetrating trauma, paratrauma. Hydrogenic, it can be because of centurion cannulation, pleural biopsy, and bronchial biopsy, etc. How do you treat this condition?
Insertion of needle in the second
Needle thoracotomy. Second
Purpose
intercostal space.
or that is emergency treatment, you can put a needle the can deposit this to drain the fluid. Permanent treatment,
ICD placement and the fifth.
ICG placement. Okay. So primary spontaneous, there is a algorithm or flow chart. Primary spontaneous pneumothorax, patient dyspnea or more than 2 centimeters on radius. There is a patient is dyspneic and pneumothorax is more than 2 centimeters. If it is not present, just observe. No need to any intervention. But if there is dyspnea and pneumothorax more than, first thing is breathing aspiration. If it is effective, just leave it at that. If it is ineffective, search just drain through intercostal space And if it is still not getting relieved, refer to specialist for low pressure suction application. Successful, remove the chest pain after 4 hours after full expansion. This is called the flow chart or the algorithm for treatment of primary mountain. This is the patient where you can take. What is shown here? The circuit diagram of a defibrillator. Name the components of a defibrillator. Okay, there is a charging unit, there is a discharging unit. It's a switch to flip from charging to discharging, and there is a paddle switch. These are the components. What are the indications for its use? When do you use a defibrillator?
Pulseless VT and VF, sir.
VT and atrial fibrillation and atrial fibrillation also is used for a version, isn't it? What is the difference between mono and biphasic waveform?
Along the
Monophasic current delivered in one direction.
on
Here from paddle it goes to, whereas in biphasic current goes in both directions. Biphasic requires lesser current strength, joule, whereas monophasic requires higher joule. Earlier it used to be 360 joules for monophasic. Now we are using only 160 to 200 because of the biphasic nature. Which component of defibrillator causes the shape and duration of wave? An operand called inductor responsible for this. What are the types of defibrillator used?
manual and automated electron.
Well, defibrillator, implantable and internal defibrillator. Now, what is shown here? Where is it used?
In intracardiac surgery.
This is called direct paddles for direct defibrillation. It is used during open heart surgery to stimulate the heart with its beating on its own after the the last line is the name of the equipment and of the person.
Taken.
Did anyone of you attend the MAC meet?
No, sir.
Okay. This is the Thromboelastography.
Egg.
Okay. With a helmet cartridge. Person who as early as body. Are the conditions that are seen in these various stages of egg. What is this? Is it normal or abnormal? That's what.
It is normal, sir.
Normal, sir.
It is normal. Here, the onset time is very much prolonged. It is on anticoagulants or it's a hemophilic patient. The clotting onset itself is take reaction time itself is very prolonged. And here this amplitude is very small. The platelet blockers, thrombocytopenia. Here the fibrinolysis is given. Reaction time is normal. Amplitude is continuously decreasing, and lysis time is reduced. So that is this is hypercoagulation. Reaction time is very, very small, and the maximum amplitude is much bigger than normal. And here DAC stage 1, it is hypercoagulable, then it becomes hypocoagulable. Comparing these two, this is stage DAC stage 1. These pictures are available. Keep repeatedly seeing this so that you can question is frequently asked again. What are the treatment options using the tech? The various results you get it are the options. So if
First is
reaction
space.
time is prolonged, normal is 5 to 8. If it is prolonged, then you have to give 30, not 80. If it is more than 11 to 14, that is the onset of clot itself is very prolonged. Go for 2 SFP, more than 14 minutes, 4. The alpha angle normal value is 45 to 74, then 45 neoprecipitate. For maximum amplitude 53 to 73 millimeter is reduced platelets. Amplitude dependent on the platelet platelet. And fibrinolysis, it is very severe, go for fibrinolytic approach. This solution a crystalloid or a colloid?
Crystallite, sir.
Crystalloid. What are the advantages of its use?
Is the correct equal of our plasmas, blood plasma.
It's called plasma light. Ionic concentration is almost equal to plasma value. Calorie content is only 21 calories. Each ml contains all these ions, sodium chloride, sodium glutamate. The osmolarity is almost like plasma osmolarity. Acetate and glutamate ions are to carbon dioxide which requires consumption of hydrogen ions. So alkalinizing effect is there. And in patients with hyperkalemia, is caution in potassium. What is strong ion difference? Concept for determining the phase value. It's the difference between the cations and anions at a given pH. What is the name for such collapsible bag infusion system?
Rapid infuser.
What is the advantage of having why did they replace it? The older days it used to come in bottles.
The another one port we will give you infusion drugs and
Another port is it for drugs.
yes,
Yeah, you
sir.
can inject drugs through this port.
Yes, sir.
But what is the
One day
advantage of
it won't leak or it won't come.
there is no airway required for this flow. It will automatically collapse slowly and the fluid will go. Okay? So this is called a closed system. See, as an example, the olden days you had to have an airway. After the smell of fluid has gone, stop flowing unless you have a vent for air to go inside and put the fluid. Whereas here it will collapse by itself. So this is the major difference, closed intravenous infusion. So infection rate is less compared to okay. Okay.